My respected teachers and learned audience, every change is a challenge to become who we really are. Myself, Syeda Jabin Saria, I'm feeling very privileged to share our team experience regarding MICS LIMA harvesting prescription to make it safe and reproducible. MICS means any procedure not performed with full sternotomy and cardiopulmonary bypass support according to STS database 2003 and according to HA statement 2008, small chest incision that does not include full sternotomy. Important steps of minimally invasive CABG: positioning and incision, LIMA harvesting, proximal anastomosis, distal anastomosis, and hemodynamic stability of the patient that is maintained by anesthesiologists. And now, why LIMA harvesting is important? Left internal mammary artery is considered the gold standard conduit for revascularization. It is routine practice in cardiac surgery to graft LIMA to the LAD to achieve benefits. LIMA harvesting is considered one of the most important steps in coronary artery bypass surgeries. LIMA harvesting is done in conventional CBG, MICS, endoscopic assisted coronary artery bypass surgery, robotic assisted coronary artery bypass surgery, totally endoscopic coronary artery bypass surgery. Now, we all know about anatomy, but still, the internal mammary artery arises from the anterior surface of first part of the subclavian artery and ends in 6th intercostal space. It has a width of between 1 to 2 millimeter. It travels downward on the inside of the rib cage, approximately 1 centimeter from the sides of the sternum. It is accompanied by the internal thoracic vein. Branches: mediastinal branches, thymic branches, pericardiophrenic artery, sternal branches, perforating branches, 12 anterior intercostal branches, and terminal branches are musculophrenic and supraepigastric artery. Histology of vein versus artery. Why are we using LIMA? Rationale of using LIMA, its endothelium produce significantly larger quantities of vasodilators such as nitric oxide and prostacyclin, resulting in greater endothelium-dependent relaxation. Additionally, endothelium-dependent relaxation factor provides better protection against histamine and serotonin-induced contractions in LIMA than venous grafts. Patency of different conduits. If we compare late outcome in angiographic follow-up after 15 years, internal thoracic artery has a patency of about 90 to 95%, but saphenous vein graft has about 50% patency. Now, the challenges that we will face while MICS LIMA harvesting. It is technically challenging, long learning curve, not suitable for every patient. Very important, the patient is positioned in a 30 to 40 degree right lateral decubitus position with an infusion bag placed under the left scapula. Key points regarding positioning and incision. Proper positioning is very important. Semi-right lateral decubitus position with the left arm extended, avoiding any traction to prevent brachial plexus injury. Surgeons should be flexible if there is any need to change the intercostal space to one space above or below, all through the same skin incision. Adhesions of either the pleura or pericardium should be carefully ablated. This picture is showing an incision, a 4 to 6 centimeter curvilinear incision. In case of man, usually just below the nipple, and in case of men, below the breast along the inframammary crease. LIMA harvesting, we are using a thoratract retractor with number 1 and number 5 blades inserted. The top end of the thoratract retractor track is connected capillate to the rolltract retractor or an arch suspensory retractor system. During insertion of the triangular thoracic retractor blade, care should be taken not to point it towards the right shoulder. Rather, it should point more towards left mid-clavicular line to prevent LIMA injury. Patient received 1.5 milligram heparin per kg body weight intravenously to achieve an activated clotting time of longer than 300 seconds. The harvesting would usually start where LIMA was better exposed and extended until LIMA bifurcation. The tip of the electrocautery was used as a dissector, and the care was taken to avoid touching the LIMA itself as much as possible. The branches were clipped and cut with a fine scissor. The LIMA can be harvested either in a skeletonized, semi-skeletonized, or pedicled fashion, combined with its accompanying vein and tissues. The LIMA was kept perfused and intact to the systemic circulation until the time of anastomosis. A solution of 60 ml normal saline and 30 mg papaverine was injected into the endothoracic fascia along the plane of LIMA. Here's a video showing that LIMA can be found medial to the intercostal space incision. LIMA may not be visualized as a whole. Better to start where it is seen more prominent. We can visualize LIMA. Branches are clipped. Dissection is done. We are using diathermy. We can see the flow of LIMA. Advantages of MICS LIMA harvesting: less post-operative pain, less recovery time, less time to come back to normal daily activities, decreased risk of superficial and deep sternal wound infection, decreased risk of mediastinitis. So we can conclude left internal mammary artery harvesting with minimally invasive technique is safe and has no negative impact on the quality and integrity of LIMA. The graft patency and post-operative outcome is comparable to conventional harvesting techniques. So, to make MICS LIMA harvesting reproducible and safe, my prescription is keep it simple. Thank you all.
Thanks, Dr. Syeda, Jabin. Excellent presentation.